Welcome to the Explainer. Okay, let's jump right in. Today, we are running through a rapid-fire review session to completely master the high-yield associations for chronic meningitis. Whether you're gearing up to absolutely dominate your board exams or you just want to sharpen those clinical diagnostic skills, this session is built to help you connect the dots and do it fast.
Look, when you're staring down a tricky exam question or worse, an actual clinical emergency, you literally do not have time to second-guess yourself. You need your brain to instantly link a patient's history straight to the right pathogen. So we're going to train your reflex pattern recognition right now, leaning heavily into the absolute best geographic clues and CSF patterns from our source material.
But first, ground rules. What exactly are we dealing with here? Well, if a patient's neurologic syndrome, persistent headache, hydrocephalus, cranial neuropathies, if that drags on for more than 4 weeks and their CSF white cell count is sitting above 5 per microliter, boom, you are officially in chronic territory. And hey, quick pro tip. Those classic meningeal signs like Kernig or Brzezinski, they're actually pretty uncommon in chronic cases, which is a huge shift from what you'd expect in an acute presentation.
All right, moving into Section 1, the crime scene. Let's look at geographic and exposure clues. Where a patient has been is honestly usually your biggest clue. Let's kick this off with a rapid-fire flashcard. I want you to instinctively answer this. Your patient is HIV positive, and the vignette specifically drops a hint about exposure to pigeons or bird droppings. What is your immediate reflex? Did you say Cryptococcus neoformans? Because you absolutely should have. It's the most common fungal cause of chronic meningitis worldwide. In an immune-compromised patient, you're going to confirm this with an India ink prep, which lights up those characteristic encapsulated yeasts, or by checking for the cryptococcal antigen in the spinal fluid. Now, endemic fungi in the U.S. follow an incredibly strict geographic map, and you just have to know it. Southwestern U.S., like the San Joaquin Valley, that's Coccidioides immitis, and keep an eye out for 6 to 20% eosinophils in the CSF. Exploring the Ohio or Mississippi River valleys, think histoplasma. And if they were hiking around the moist, wooded soils of the southeast, lock in blastomyces. It's like a giant geographic puzzle. Okay, next flashcard. Picture this. Your patient has subacute meningitis, maybe some cranial neuropathies, and the history notes they just got back from a Mediterranean vacation where they were eating artisanal raw cheese or drinking unpasteurized milk. What's the bug?
You gotta lock in neurobrucellosis for this one. Brucella species absolutely thrive in unpasteurized dairy. And to make sure you're on the right track, the exam will usually throw in a couple of extra clinical hints, like severe joint pain or hepatosplenomegaly, right alongside those neurosymptoms.
Now, this is where it gets kind of wild. All three of these highly specific global exposures share a single striking lab finding. Eating raw freshwater fish in Thailand leading to gnathostoma, eating raw snails in Hawaii causing angiostrongylus, the rat lungworm, or maybe a kid playing near raccoons in a rural area getting Balis ascaris. Every single one of these triggers the exact same specific profile, eosinophilic meningitis. Which brings us perfectly to Section 2, decoding the lab evidence. Let's break down those CSF differentials. So you've scoured the geographic crime scene, now let's look at the fluid evidence itself. Here is the absolute crux of it. In the vast majority of chronic cases, TB, crypto, neurosyphilis, the CSF is going to show a mononuclear or lymphocytic predominance. But if you are seeing a persistent neutrophilic pattern after 3-4 weeks of symptoms, stop. Hard pivot. That delayed neutrophilia strongly points you toward nocardia, actinomyces, brucella, or certain weird fungal infections. Let's circle back to eosinophils for a second because it's super important. When you see eosinophils in the CSF, your brain should immediately scream parasites, like the ones we just talked about, plus Taenia solium causing neurocysticercosis. Also, remember Coccidioides from the Southwest. But watch out, because here is the classic trap. Do not forget that malignancies, specifically lymphomas and leukemias, can mimic this exact eosinophilic pattern perfectly. All right, we need to make a really vital distinction here between chronic and recurrent meningitis. When you're reading a vignette, pay extremely close attention to the phrase complete resolution. If a patient has an episode, but then their symptoms and their CSF return to totally normal before the next attack, that's not chronic persistent. That is recurrent episodic meningitis. The absolute classic board example here is Muller-Retz meningitis, usually caused by HSV type 2. And if the bug hunt turns up totally empty, recurrent aseptic meningitis is a massive red flag for autoimmune conditions. Look for the physical giveaways. Recurrent meningitis with a triad of aphthous oral ulcers, genital ulcers, and uveitis, that's Behçet's syndrome all day.
Meningitis paired with uveitis, hearing loss, and vitiligo, you're looking at Vogt-Queen-Augy-Hirata syndrome. Those exam findings are dead giveaways.
Let's talk imaging really quick. If you have to guess the etiology just based on an MRI, look at how the meninges are enhancing. Leptomeningeal enhancement, meaning it's tracking deep into the sulci or pooling at the basal cisterns, heavily favors an infection like TB or Cryptococcus. But pachymeningeal enhancement, that's a thick, chunky rind along the dura that doesn't go into the sulci, that points you straight to lymphomatous meningitis or an IgG4-related disease.
All right, Section 3, the climax, the low glucose emergency. This is it, the absolute highest stakes scenario in our diagnostic journey. Waiting around for a culture here will literally cost the patient their life. Finding low glucose in the CSF is a dire clinical clue. Right off the bat, it emphatically rules out your typical viral causes. More importantly, it narrows your suspect list down to bacterial, fungal, carcinomatous, or TB meningitis. It mandates immediate aggressive action. TB meningitis does not care about your culture wait times. It is devastatingly fatal within weeks if you miss it. So the second you see low glucose paired with lymphocytic pleocytosis, you shoot first. It's a three-pronged empirical punch. Step 1, hit them with anti-TB drugs immediately. Step 2, add amphotericin B to cover the deadly fungi. Step 3, add glucocorticoids to manage the brain inflammation and cover non-infectious causes. But this brings us to a terrifying clinical trap, and I want to leave you with this thought. Say you give a patient steroids, and suddenly their chronic meningitis symptoms start to improve. Are they cured? Actually, scratch that. Since steroids temporarily shut down inflammation, could they just be falsely reassuring you by masking a deadly infection like TB or maybe a hidden lymphoma? How confident are you really in that quick recovery if you haven't secured the definitive diagnosis? It is a dangerous game, and it proves exactly why mastering these reflex clues is absolutely crucial. Thanks for hanging out with me on this explainer. I'll catch you next time.